Imagine like going to the doctor because your memory is just completely shot.
Oh, yeah. That is terrifying.
Right. You physically cannot drag yourself out of bed, and you've entirely lost the ability to taste or even enjoy your absolute favorite meal.
You immediately think the worst, right.
Exactly. You are convinced you are experiencing early onset dementia or maybe a severe psychiatric break. So you sit in the sterile exam room, totally terrified, and the doctor looks at your blood work and says, well, you just have a severe vitamin deficiency.
Wow, yeah. It is wild how the human brain is so easily tricked by its own body.
It really is, and today we are looking at exactly why that happens. We are moving past the really casual way we throw around the word depression.
Because people use it all the time for just a bad Tuesday.
Yeah, exactly. So we are taking a deep dive into the intense, systemic, clinical reality of major depressive disorder.
Because we need to dissect the actual mechanics of an illness that fundamentally alters how a person interacts with the world.
Right, and for this deep dive, we're leaning on a really comprehensive clinical overview and treatment protocol. This was provided by Coping and Healing Counseling, or CHC.
Yeah, they're a telehealth practice that navigates these exact diagnostic trenches every single day.
Yeah.
So we are stripping away the colloquialisms to look at the strict biological and diagnostic parameters.
Okay, let's unpack this, and I think we should start with the clock.
Yes, the clock is critical here.
Because the clinical standard, like the DSM-5 criteria, dictates that true clinical depression is not having a bad week at work.
No, not at all.
And it isn't feeling down because the weather has been terrible for a few days. It requires a really specific cluster of at least 5 symptoms.
And they have to occur continuously over a strict 14-day period.
2 full weeks.
2 full weeks of, unyielding systemic change, a state that drastically deviates from your normal baseline of functioning.
And of those 5 required symptoms, the diagnostic criteria mandates that at least one of them must be either a deeply depressed mood or anhedonia.
Right. And anhedonia is a concept that truly highlights the mechanical failure happening in the brain.
Yeah, it's usually described simply as a loss of interest or pleasure, but functionally, it's like a blown fuse in your brain's reward circuitry.
Oh, that's a really good way to put it.
Like, you can plug in the lamp,
Right.
you can eat that favorite meal or watch your favorite movie or even hug your child, but the wiring is just severed.
The electrical signal for joy simply doesn't reach the bulb.
Exactly. It's not that you feel sad about the food or the movie. It's a profound, unsettling emotional flatness.
What's fascinating here is how that blown fuse analogy perfectly captures the neurobiology at play.
Like chemically, right?
Right, because we are talking about a malfunction in the dopaminergic pathways.
Yeah.
The brain is literally failing to synthesize or properly utilize the neurotransmitters responsible for anticipating and processing reward.
Wow.
And when we examine the other symptoms required for that diagnosis of major depressive disorder, or MDD, the evidence of a systemic whole-body shutdown just becomes undeniable. It goes far beyond mood.
Yeah, it bleeds into core physiological functions. Like, we are looking at significant unintentional weight fluctuations.
Huge swings in appetite, yeah.
And massive sleep disturbances. And not just general insomnia, but very specific circadian disruptions.
Right. The clinical data points to early morning waking as a classic hallmark sign of MDD.
So waking up at like 3 or 4 in the morning.
Yeah, waking up 3 or 4 a.m. and being entirely unable to fall back asleep. It indicates a severe disruption in sleep architecture.
Because cortisol comes into play there, right?
Exactly. In a healthy brain, cortisol, the stress hormone, naturally begins to rise in the early morning to kind of prepare you to wake up.
But in an MDD-afflicted brain,
the hypothalamic pituitary adrenal axis, the system managing stress, is often just hyperactive. So that cortisol spike hits way too early and way too hard.
oh, wow. So it violently pulls the person out of REM sleep.
Yeah, and locks them in a state of exhausted hyperarousal.
Hmm.
They're dead tired, but
Yeah.
completely wired.
Okay, here's where it gets really interesting to me. The physical manifestations of MDD extend to movement itself.
Yes, through psychomotor agitation or slowing.
And psychomotor slowing isn't just feeling tired, it is a visible neurological lag. People describe feeling like their limbs are filled with lead.
Or like they are trying to move and speak while submerged in thick molasses.
Yeah, exactly. The basal ganglia, which is the part of the brain that helps initiate fluid movement, is essentially starved of dopamine.
And on the opposite end of that spectrum is psychomotor agitation, which presents as a relentless, uncomfortable pacing or hand-wringing.
Just an absolute inability to sit still.
Right. It is a physical manifestation of internal neural chaos. So you add in profound fatigue, a total loss of executive function resulting in an inability to concentrate or even make basic decisions.
Plus crushing feelings of worthlessness.
Exactly. And recurrent thoughts of death or suicide.
Yeah.
Then you have a complete picture of MDD.
And crucially, for a clinician to actually make this diagnosis, these symptoms must cause clinically significant distress or impairment, like in social or occupational functioning.
You cannot just power through it.
Right, you can't just power through without it fracturing your life, and it cannot be the result of substance abuse.
No, it has to be a rigorous 14-day baseline of systemic failure.
Which forces us to look at the sheer scope of this illness, because the clinical prevalence statistics are, frankly, staggering.
They really are.
The 12-month prevalence in U.S. adults is 8.4%, and the lifetime prevalence hovers around 20.6%.
With women being diagnosed at roughly twice the rate of men.
That means 1 in 5 adults will experience this clinical shutdown. But I have to push back on those numbers a little bit.
Okay, sure.
In an era where everyone is hyper-aware of mental health, are we maybe overcounting? Like, does that 1 in 5 statistic include people who just took a quick late-night online quiz, got a bad score, and self-identified as having MDD?
That's a fair question, but no. A true epidemiological prevalence statistic relies on rigorous clinical standards, not self-reported internet quizzes.
Okay, so what are the quizzes then?
You are likely referring to screening tools like the PHQ-9, the Patient Health Questionnaire. The PHQ-9 is a highly validated, really excellent tool for tracking symptom severity. But it is strictly a screening mechanism.
It's just the first step.
Right. A legitimate MDD diagnosis requires a structured clinical interview and a detailed psychiatric history, and that has to be administered by a licensed clinician.
So a psychologist or a licensed clinical social worker?
Yes, an LCSW or a licensed professional counselor, a licensed marriage and family therapist, or a psychiatrist.
Got it. So the clinician acts as the diagnostic firewall.
Exactly. They evaluate the severity, the duration, and the functional impairment to filter out transient sadness. And the accuracy of that clinical filter is absolutely vital.
Because untreated MDD is a leading cause of disability worldwide.
It actively degrades physical health, it destroys relationships, it basically decimates occupational productivity. And suicide remains the second leading cause of death among young adults in the U.S.
That is just heartbreaking, but it really makes the clinical interview the most critical juncture in the entire process.
It is. The clinician is searching for the ground truth of what is happening in the patient's body and mind.
Which brings us to the concept of differential diagnosis.
Yeah.
Because they have to rule out the mimics.
Oh, the mimics are so important to understand.
Because a surprising number of conditions perfectly replicate the symptoms of major depressive disorder, right? But they require entirely different treatments.
Correct. And the first major psychological mimic to separate from MDD is normal, uncomplicated grief.
Which feels like a really delicate distinction to make. If you lose a loved one, you are naturally going to exhibit symptoms that mirror depression.
Of course. You might stop eating, your sleep architecture will likely fracture, you will experience profound sadness.
So how do they tell the difference?
The clinical distinction lies in the pattern and the self-concept. Normal grief tends to arrive in waves or pangs, and it's usually tightly coupled to specific memories or reminders of the loss.
Oh, okay.
The intense sadness washes over the individual, and then it temporarily recedes.
Whereas MDD is just a constant, suffocating blanket that doesn't lift, regardless of the stimulus.
Right. Furthermore, in normal grief, the person's fundamental sense of self-worth remains largely intact. They are mourning a profound external loss. They aren't consumed by internal self-loathing or feelings of worthlessness.
That makes a lot of sense. And suicidal ideation is also relatively absent in normal grief, whereas it is a frequent, incredibly dangerous component of MDD.
Exactly. We also have to differentiate MDD from an adjustment disorder.
Right, which is a maladaptive reaction to a clear, identifiable stressor, like a sudden job loss or a divorce.
Yeah, and it is inherently time-limited. But the differential diagnosis that truly highlights the complexity of the human body involves the physical mimics.
The medical conditions masquerading as psychiatric ones. This is where that vitamin deficiency scenario from the beginning comes into play.
Right, because the clinical literature identifies severe anemia, vitamin D and B12 deficiencies, and thyroid disorders as huge mimics.
Specifically hypothyroidism, right?
Yes, plus sleep apnea. All of these are conditions capable of producing identical depression-like symptoms.
This raises an important question about our modern awareness-heavy culture, because if you feel profound fatigue, brain fog, and a total lack of motivation, the immediate cultural instinct is to assume a psychological root
You
cause.
automatically assume you are depressed.
Right. But if you skip the comprehensive medical evaluation, you might spend years trying to, talk therapy your way out of a physiological hormone deficit.
And you literally cannot out mindfulness an underactive thyroid gland.
No, you really can't. If your thyroid isn't producing enough hormones, your basal metabolic rate plummets. Your brain slows down, your energy vanishes, and you develop psychomotor slowing.
It looks exactly like MDD.
Yeah.
But the treatment is synthetic hormones, not antidepressants.
Or take sleep apnea. If you are waking up microscopically 30 times an hour because you physically stop breathing, you are never hitting deep REM sleep.
No, your brain is just constantly fighting to survive.
And after 6 months of that, you will present with clinical anhedonia, severe executive dysfunction, and depressed mood. The validation a patient must feel when a doctor hooks them up to a CPAP machine and, quote-unquote, cures their depression in 2 weeks must be unbelievable.
It underscores the absolute necessity of laboratory workups and a holistic medical view before finalizing any psychiatric diagnosis.
Definitely. But once those physical mimics and the adjustment disorders and normal grief are definitively ruled out,
Right.
and the licensed clinician confirms the presence of major depressive disorder, the focus shifts to intervention.
Because if the disease has effectively tricked the brain into a state of systemic shutdown, how do we manually reboot the system?
Exactly. We pivot to the arsenal of evidence-based treatments. The clinical protocol attacks the illness from both the psychological and the biological fronts.
Let's look at the psychotherapies first. The data heavily supports cognitive behavioral therapy, or CBT.
Okay, so CBT operates on the premise that our thoughts, feelings, and behaviors are deeply interconnected.
Right. It trains patients to actively identify and dismantle cognitive distortions.
Those are the irrational, deeply negative thought loops that MDD implants in the brain, right?
Exactly.
Uh-huh.
You identify them and replace them with objective reality. Alongside CBT is behavioral activation, or BA.
So while CBT targets the thought process, BA targets the anhedonia directly.
Yes. Because MDD strips away the anticipation of reward, patients naturally withdraw from activities. Behavioral activation essentially forces the re-engagement with life.
It requires the patient to schedule and execute activities even when they feel zero motivation to do so.
Because it utilizes the behavioral principle that action can actually precede motivation. By forcing the behavior, you eventually force the dopaminergic pathways to start firing again.
You act your way into a new way of thinking, rather than trying to think your way into a new way of acting.
You perfectly said. The protocol also includes interpersonal therapy, or IPT, which looks at the social friction, role transitions, and relationship conflicts that either triggered or are exacerbating the depressive episode.
Okay, so those are the primary psychological levers. What about the biological levers?
Those come in the form of pharmacotherapy, primarily utilizing antidepressant medications that target the synaptic cleft.
Which is the microscopic gap between neurons where neurotransmitter signaling occurs?
Exactly. The frontline medications are SSRIs, selective serotonin reuptake inhibitors like sertraline, escitalopram, and fluoxetine.
To understand how an SSRI actually works, you kind of have to picture the brain's communication system. So when one neuron wants to send a mood signal to the next, it releases serotonin into that gap, the synaptic cleft. Once the message is received, the first neuron essentially vacuums the leftover serotonin back up to recycle it.
Right, it reuptakes it.
An SSRI blocks those microscopic vacuum pumps. It prevents the reuptake, leaving the serotonin floating in the gap longer.
Which effectively turns up the volume on the signals governing mood, sleep, and appetite. We also utilize SNRIs, serotonin, and norepinephrine reuptake inhibitors.
Like venlafaxine and duloxetine.
Right. And those block the recycling of both serotonin and norepinephrine, so they target energy and alertness alongside mood.
But the clinical data is definitive on the most effective approach for moderate to severe MDD, isn't
Oh,
it?
absolutely. The gold standard is combined treatment.
Utilizing psychotherapy and pharmacotherapy together generally outperforms either approach used in isolation.
It is a synergistic effect rooted in neuroplasticity. The medication chemically primes the brain, creating an environment where new neural connections are easier to form.
And then the psychotherapy provides the blueprint, actively carving out those new, healthier cognitive pathways.
We hit it with the chemistry and we mold it with the therapy.
But, MDD can be incredibly deeply entrenched. The clinical overview explicitly outlines protocols for treatment-resistant depression as well.
Yes. When the frontline therapies and the standard SSRIs fail to produce remission, clinicians deploy augmentation strategies and neurostimulation.
Right. And if we connect this to the bigger picture, the sheer variety of these interventions reflects the staggering complexity of the human nervous system.
It really does. We have electroconvulsive therapy, or ECT, which remains one of the most highly effective treatments for severe refractory depression.
That's using controlled electrical currents to induce a therapeutic microseizure, right?
Yes, which rapidly resets neural firing patterns.
Yeah.
We also have TMS, transcranial magnetic stimulation.
So instead of electricity, TMS uses highly targeted magnetic pulses aimed directly at the prefrontal cortex.
Because that's the area of the brain responsible for mood regulation and executive function. So TMS literally stimulates the underactive nerve cells.
And the protocol even includes the use of ketamine or esketamine, which operates on an entirely different neurotransmitter system.
Right, glutamate.
And that rapidly generates new synaptic connections in a matter of hours, rather than the weeks it takes traditional antidepressants.
It's incredible. But even after successful intervention brings a patient into remission, the clinical reality is that MDD is often an episodic illness.
So it comes back.
It can, yeah. Relapse prevention is a critical phase of treatment. The data heavily supports mindfulness-based cognitive therapy, or MBCT, for maintenance.
How does that work?
Well, MBCT trains recovered patients to observe their thoughts non-judgmentally. It allows them to recognize the earliest warning signs of a downward mood shift without emotionally attaching to it.
Which effectively stops a new episode before it fully takes root. So we have this robust, scientifically validated arsenal of treatments. We can rewire the thoughts, we can force the behaviors, alter the synaptic chemistry, and magnetically stimulate the cortex. The roadmap to remission exists.
It does.
But, and here is the cruel, almost paradoxical irony of major depressive disorder, the disease itself actively destroys the exact mechanisms you need to access the cure.
Oh, completely. The barrier to entry in the traditional healthcare model is heavily reliant on executive function, motivation, and physical energy.
Think about it. If you are experiencing profound psychomotor slowing to the point where lifting your arm feels like moving boulders,
Yeah.
and your executive function is so fractured you can barely decide what to eat for breakfast, how on earth are you supposed to navigate a clunky insurance portal?
You can't.
How do you call 5 different clinics to find someone accepting new patients, commute 45 minutes across town, and sit in a bright, loud waiting room?
You just don't. The illness locks you behind a wall,
Hmm.
and the traditional healthcare system basically puts the ladder on the outside.
Right, which is why the structural delivery of care is undergoing a massive shift. The Coping and Healing Counseling Model, CHC, which provided our clinical overview, serves as a prime case study in adapting healthcare architecture to the biological reality of the disease.
Because they operate as a 100% telehealth therapy practice.
Right, serving all 159 counties across the state of Georgia.
And by utilizing a HIPAA compliant digital platform and a diverse team of over 15 licensed therapists, those LCSWs, LPCs, and LMFTs, they entirely eliminate the geographical and physical commute barriers.
You literally do not have to fight through psychomotor agitation in a waiting room.
Exactly. But navigating the logistics is only half of the systemic barrier.
Yeah, the financial barrier is often the final nail in the coffin for someone seeking help, and the CHC structure actively dismantles this.
Right, because for patients utilizing Medicaid, there is a $0 copay.
Removing the financial friction entirely for some of the most vulnerable populations.
And for patients with major commercial insurance, they accept Aetna, Cigna, Blue Cross Blue Shield, United Healthcare, Humana. The out-of-pocket cost is negotiated down to range from just $10 to $40 a session.
And they offer same-week availability, entirely bypassing the 3-month wait lists that plague the industry.
Plus, they utilize the PHQ-9 not just as a one-time screener, but as a continuous tracking tool, so progress is scientifically measured over time.
And critically, they coordinate directly with the patient's prescribing physicians.
To ensure that gold standard combined approach of therapy and medication is seamlessly executed. They're essentially building the supportive infrastructure around the patient rather than demanding the severely depleted patient build it themselves.
It adapts the delivery mechanism to the symptoms.
It really does.
So a telehealth model with same-week availability and a $0 Medicaid copay isn't just a modern technological convenience.
No, for someone suffering from severe anhedonia and an absolute inability to leave their bed, this low-barrier access is a literal lifeline.
It brings the clinician, the diagnostic firewall, and the evidence-based therapy directly into their living room.
It flips the script from, I don't have the energy to find help, to the help is already right in front of me.
It's a systemic solution to a systemic illness.
Exactly.
So as we pull back and look at everything we've covered today, the narrative surrounding mental health takes on a much sharper edge.
It has to.
Major depressive disorder is not a string of bad days, and it isn't an inability to handle normal stress. It is a rigorous 14-day clinical reality marked by profound physiological changes.
From circadian rhythm disruption and dopamine depletion all the way to severe cognitive impairment.
But the clinical data also provides a definitive roadmap.
Yeah.
Once the physical mimics like thyroid dysfunction or sleep apnea are ruled out by a medical professional, MDD is highly treatable.
Through that combination of neurochemical intervention and targeted psychotherapy.
The actionable advice derived from the clinical overview is clear. If you or someone you know have experienced at least 2 weeks of continuous depressed mood or a profound loss of pleasure, accompanied by the systemic symptoms we unpacked today.
And especially if there are recurrent thoughts of death.
Yes, absolutely. Do not try to self-diagnose. And do not try to out-stubborn the biology. Reach out to a licensed therapist or a primary care provider.
The clinical tools exist, and models like telehealth are actively removing the barriers to access them.
So if you are located in Georgia, the clinicians at CHC can be reached directly at 404-832-0102. Their platform is accessible at sheettherapy.com, and their intake team can be reached via email at support@sheettherapy.com.
And importantly, if you are in immediate acute crisis, regardless of where you live, please dial or text 988 for the Suicide and Crisis Lifeline.
Yes, there is a trained professional ready to intercept that crisis 24/7. So what does this all mean? We started by talking about the terror of thinking you are losing your mind, only to discover a severe vitamin deficiency. The human body is a deeply interconnected machine, and major depressive disorder proves that mental health is quite literally physical health.
The brain is an organ, and it is susceptible to systemic failure, just like the heart or the lungs. And, analyzing the sheer biological weight of this illness leaves me with this final thought for you to ponder.
What's that?
If 20% of adults, literally 1 in 5 people, will experience this energy-draining, cognitive fracturing illness in their lifetime, and we clinically know that it severely alters sleep architecture, appetite, motor function, and executive processing, how might modern society and corporate culture need to completely rethink workplace sick leave and productivity expectations?
Wow, yeah.
If we truly accepted the invisible physical toll of the human mind as equal to a broken bone or a torn ligament, how would the world need to change to accommodate it?